Welcome to our Qyral educational series. I'm Honey Sagari, founder and CEO of Qyral, and today we have a very special guest joining us, Dr. Matt Sager. Thank you so much for being here. I'm so excited about our discussion. Let's talk about you a little bit. He's a cardiologist fellow at the Texas Heart Institute. Dr. Sager graduated from internal medicine residency at UT Southwestern Medical Center and received his medical degree from the Indiana University School of Medicine. Beyond being a physician, Dr. Sager conducts research that focuses on using machine learning and AI to improve risk prediction and tailor medical therapies to identify and treat heart failure. That was a mouthful, but we're gonna get into that.
You did great. You did great. Thank you so much. I'm very excited to be talking with you guys.
Yeah, thank you for joining us today. We're so excited to talk about all the extra benefits of GLP-1s beyond weight loss. So, Dr. Sager, we had an opportunity to quickly chat before the call. Let's start from the beginning. Tell us about your background because it's really interesting. And you've been part of this for a long time. Like to us, semaglutide, tirzepatide, a lot of us are just hearing about it, but you've been part of this journey for a very long time. So tell us a little about your background and a little more. Go ahead.
Absolutely. Well, again, thank you. So my background is completely opposite of medicine. It actually started with computer science, was a programmer prior to medical school, but missed that human interaction. So made the switch to medicine, really enjoyed everything that I was doing, did internal medicine, and then came across kind of this new area that was just happening in cardiology and the diabetes space with these whole new classes of medicines, SGLT2 inhibitors that have since blown up from 2015 onward. And the story of these is kind of rooted in serendipity, where we've kind of just by happenstance found that these incredible medicines work to improve cardiovascular risk, not just diabetes. So naturally, my interest then turned from SGLT2s to the GLP, GIP class of medications. Have been very fortunate to work with some of the largest diabetes and cardiovascular disease trials, and have a lot of stuff in the pipeline as well. I was there in November at the American Heart Association meeting when they announced the big semaglutide results. It was as much of a rock star event as you can imagine for a cardiology conference, with a standing ovation. So this is a pretty exciting time with these medications and medicine in general.
Yeah, we're going to get into that. I'm really excited to talk about it. But let's take a step back for individuals who are just being introduced to these classes of drugs, GLP-1s, GIPs. Can you talk to us a little bit about how they work and some of the benefits, some of the overall benefits?
Of course. So GLP stands for glucagon-like peptide 1, and it's a specific type of hormone that is typically found in the gut and intestines. And the medication itself acts as essentially a mimicker of GLP-1, and it was initially used to treat diabetes. The way that this medicine works is after eating, GLP is released from the gut and intestines, and it increases insulin levels in response to those high blood sugar levels. So these medications for diabetes help lower blood sugar. It also acts by doing something else that's really important, which is suppressing glucagon, which is another hormone. Glucagon raises blood sugar. So by blocking that release, you can also lower blood sugar levels. And then it does two extra things that are really fascinating. One is slowing gastric emptying. So food sticks around the stomach longer. It helps control our appetite and food intake. And then what we're starting to find out is it actually helps directly affect the brain centers and these things that help control satiety and hunger as well.
Interesting. Now, how about, I know with tirzepatide, for example, there's also the process of lipolysis and fat burning. Can you talk to us about that a little bit?
Yeah, so some of the enzyme or hormone effects also play a really important role in just decreasing inflammation. It actually activates some of the enzymes we have in our liver to do a lot of really important things by decreasing lipid levels, converting fat into other nutrients that can be used more effectively and favorably. And those are a lot of the reasons we think that medications have such good cardiovascular health benefits.
Oh my gosh, I'm so excited to talk about that with you. But before we go there, what role do GLP-1 receptor agonists like semaglutide, tirzepatide play in maintaining long-term weight loss? And how do they prevent yo-yo dieting or weight regain?
Great question. So this is probably the most common question we get is how do these medications help long-term weight loss? So they do this primarily by delaying gastric emptying. So by reducing the appetite and the amount of food we intake, this leads to an overall calorie deficit. Now, that's not the only way these medications work. They also help slow gastric emptying, but they also help with the, like you said, the yo-yoing effect by keeping our basal metabolic rate, the overall calorie expenditure we have in our body, at a nice steady level, so that we're not doing these big fluctuations in our intake and output on a weekly or monthly level. We get to say this nice even level with a nice even level of medication dosing. Now, you can see a little bit of the yo-yo effect in the beginning stages of just starting the medication, because we are titrating the medicine until you reach that steady state. But once you are on a good, healthy, stable dose, it really works well. And the trials have also shown this. If you look at the graph of weight loss, you have this big drop and then this plateau. And as long as you're on the medication, you have this really nice, sustained weight loss effect.
Mm-hmm. So let's talk about the two big ones, the semaglutide and the tirzepatide. For those individuals who are not yet familiar with these classes of medication, can you tell us the difference between the two and which one is better ultimately?
So, a great question. So they work very similarly. So they both have the GLP-1 agonist component, both semaglutide and tirzepatide. Tirzepatide also has another component, which is the GIP, the glucagon immunomedic peptide. I can never say that word, but it's essentially the glucagon portion that I was alluding to earlier, to also help lower glucagon levels. Now, what's interesting is there's actually a third medicine that's not really well known. That's called retatrutide. That's just becoming on the market. Some of the studies are pretty early, and that's also a glucose inhibitor as well. And those weight loss effects are even more so than tirzepatide. So when you think of the number of hormones that are blocked or supported or acted upon, that's typically the order in which they have the weight loss effect. So you see a good amount of weight loss with semaglutide, you see even more with tirzepatide, and even more so with a retatrutide, which doesn't have a brand name just yet.
Okay, so before we talk about all the great benefits, which is going to be a majority of our conversation, let's talk about side effects. What are typical side effects of semaglutide, tirzepatide? What can typical
Of
patients
course.
starting? And then maybe you could talk to us why we titrate patients slowly. Like people come to us, they're like, no, I want to be at 1 milligram of semaglutide. Why do we titrate them up?
Yeah, great question. So by far and away, the most common side effect that you're going to see is what we would expect. Because the medication slows gastric emptying, food sticks around the stomach longer, you're going to feel nauseated. That's expected. Most people feel nauseated. In fact, I would say almost half of people feel some sort of nausea when starting the medication. That's exactly why we want to start at the low dose and then titrate up, to help mitigate some of those side effects that we're going to be expecting. So you start low, a little nausea, that tends to go away in a couple days. And then usually after we dose increase, so go from 0.25 to 0.5 of semaglutide, usually that you see a little bit more nausea immediately after the dose titration that goes away within usually 72 hours or so. The other big one that I can't counsel patients on is bowel upset. Some people get diarrhea, some people get constipation. It's impossible to predict which one a patient's going to get. The best thing I always tell people is stay hydrated. The worst thing we can do is eliminate completely certain types of things that we would normally do, like drink water. So stay hydrated, make sure that your GI system is still active, and then that can really help mitigate some of those side effects. And then finally, anecdotally, this hasn't been shown in clinical trials, I'm a big fan of also giving a little bit of vitamin B12 with some of these medications. I found that it helps the nausea effect a little bit. And in fact, some of the compound pharmacies have started to adopt this approach as well. And that's actually being hopefully instituted in some of the brand formulations as well. So pretty exciting ways to mitigate some side effects.
And some acid reflux. What's causing the acid reflux? We get that a lot too.
Great question. So the acid reflux happens occasionally. It's about 1 in every 10 to 1 in every 12 patients. And the reason is very similarly, you have food sticking around the stomach. If it can't go through the rest of the digestive system, some of the acid effects can come up through the esophagus and cause some burning. Again, very easy if you're someone that takes Tums or antacid medication, it can really help eliminate some of those side effects.
Okay, awesome. So you've been in the research world and you've seen some of the data. Let's talk quickly about long-term side effects, because the people come to us and they worry a lot about these medications. And I'm like, there's so many greater benefits. First of all, your obesity is probably the bigger problem. Like that's where you should really be scared of, obesity. But everyone's scared. But let's talk about that. It's something we should shed light on. Have you read any studies or have you conducted any studies that talk about the long-term disbenefits of being on these drugs? Because we don't really know much about that, right? Besides diabetes.
Yeah, so that the medication has been around a lot longer than people think. So the GLP-1 agonist class has actually been around since 2004. So a sister medication of semaglutide has been around for a very long time, and there's been other formulations that have come out along the way. It's just that semaglutide has the best weight loss effect of that class of medications, but we've been using it for almost 2 decades now. So we have very good long-term outcomes dating back to the late 1990s for when the first clinical trials started. Now, there are some people who should absolutely not be on these kinds of medications. Those are those that have history of things like pancreas cancer or certain syndromes like MEN syndrome, which is a endocrine hormone type tumor or condition. Absolutely do not take the medication, but the long-term side effects are pretty minimal. Like you alluded to, the long-term risks of obesity far outweigh the long-term side effects of the medication. So that if you're maintaining a good appetite, you're still getting enough protein, still maintaining a balanced diet, you're not going to see the sarcopenia, the muscle wasting that some people can experience. And a lot of the side effects can be pretty well controlled with simple things like water, antacid medicines, or a couple other symptomatic treatment type therapies.
Okay, awesome. All right.
Excited golden doodle. Sorry about that.
No, it's totally fine. He's welcome to join us. So let's talk about why we're all here. We want to hear about the other benefits of these classes of medication. So you're a cardiologist. Let's start with heart health. Tell us what you're seeing, what you're reading, what you're seeing out there. Tell us all about it.
Yeah, so this is the most exciting area in cardiology right now, on finally having a medication that can improve cardiovascular benefit across the spectrum. So the largest clinical trial we have, like I said, came out in November, the STEP study, and it absolutely blew our socks off with how well the outcomes were. So this medication from a heart standpoint helps reduce nearly every outcome they looked at: cardiovascular death, heart failure, stroke, heart attacks, and then amazingly, all-cause mortality, meaning dying of any cause. In other words, the medication helps people live longer. If you can help people or prevent them from dying of any cause, that is another way of saying you're helping people live longer by being on this medication. And that's just the major outcomes. Some of the other outcomes that they looked at were blood pressure effects, improved kidney function. Having a medication that can slow the progression of kidney disease is astronomical. And then also things like metabolic syndrome, cholesterol levels were also improved as well. So I can talk about this for hours, and we can absolutely elaborate, but it's a really exciting time.
Do you foresee them approving this long-term for heart disease? Like this right now, it's approved for diabetes and weight management. Do you foresee that happening in the future?
Absolutely. And I think they've begun to do that a little bit. So the enrollment criteria for this trial is a lot of times how the insurance companies end up choosing who qualifies for the medication. So you could qualify for this study in one of two ways. You could either have a BMI above 30, or a BMI of 27 with some sort of chronic condition, whether that's hypertension, hyperlipidemia, a history of a stroke or heart attack in the past. So these are patients that have risk factors for cardiovascular disease that we're showing benefits these exact types of patients and conditions. So absolutely, it's another tool in our arsenal that we have to combat the rising prevalence of cardiovascular disease.
Interesting. I just had a question come in. Can an individual with a pacemaker use these compounds?
Absolutely. So a little tidbit into the research that I'm doing next is looking at the electrocardiographic, meaning the conduction system, the electrical system we have in our heart. It's hypothesized that some of these medications can improve the conduction system in our heart by decreasing fibrosis. In other words, making the electrical highways of the conduction system in the heart stronger is the hypothesis that we have. So stay tuned for some of those results. But yeah, there's no contraindication to pacemakers.
Wow, very, very interesting. Now, you touched on this, but how do GLP, GIP affect cholesterol levels and blood sugar? That's another question.
Excellent question. So the blood sugar specifically is mitigated by the actual action of the enzyme itself. So glucagon-like peptide or the hormone itself lowers glucose by raising insulin levels. The ways that we treat hyperlipidemia and cholesterol levels are a little bit more complicated, and this is an area that we're still exploring. A lot of it has to do with the anti-inflammation effect. So TNF alpha, IL-1 have been shown to be decreased in this medication. It also activates a specific enzyme in the liver to help convert the bad cholesterol into good cholesterol in a way, and then help uptake the bad cholesterol into the body to be exported out. This also can be seen in some of the vascular studies as well, where some of those cholesterol gets kind of sucked up into the foam cells and other collecting cells of the body that are then transported to the elimination system of the body to get rid of bad cholesterol.
Yeah, it's really interesting because we talk about this sometimes where people are like, well, I'm not losing weight. And it's like, well, if you were to compare your lab markers, you would definitely see and notice a difference. Now, I want to talk about that. We had someone that had lost about 30 pounds or so, but her blood pressure went down significantly. Like we're talking about, it went from 160 down to normal levels over a very short period of time. Is that due to the weight loss, or is that the medication at work, improving the heart functionality?
So great question. I think it's a combination of probably a lot of things. So the first question, the one that we just have to get off the bat is, I want to make sure that the person's hydrated. I want to make sure they're still, eating and drinking and making sure that the pump is primed, that we're not missing something obvious when somebody presents like that. But there are really good blood pressure effects with the medication, and it's really fascinating in how that works. So it actually decreases levels of vascular stiffening. So naturally, as we get older, our arteries tend to get a little bit harder due to fibrosis and other inflammatory type pathways. And this medication works by decreasing those exact pathways. Like I said, the foam cells, macrophages that are inundated within the vascular endothelium become, in other words, transformed into a way that doesn't cause those inflammatory type processes. So when your muscles and vasculature can relax, naturally the pressure can come down. The other thing is just your body weight and habitus in general. When the heart doesn't have to pump as hard to pump blood through the body because you've lost weight, there's less mass in general, you're going to have lower pressure. So it's probably what we call pleiotropic, meaning a multi-modality way that blood pressure can be reduced.
My gosh, that's exciting. We just had a question that came in. Do you see a time when GLP meds replace statins? Do you agree with that, especially since statins increase the risk of diabetes and dementia?
That's a amazingly good question. So even though statins have been around for almost 40 years now, there's still things that we're learning about them. And one of the things that is becoming a little bit more common is this hyperglycemia risk. The diabetes risk is still a little bit puzzling. it does raise blood sugar levels. Whether that translates into diabetes is still a little bit nuanced. But I think that the benefits of statin are additive in addition to semaglutide, tirzepatide. They work in different methods. You have acetyl-CoA enzyme inhibitors versus enzyme inhibitors within the liver itself. They work synergistically in a way. The other thing that can happen is the decrease of fatty liver disease with these medications can also help cholesterol levels. But I wouldn't say we're getting away from statins. I think that they play a really nice role in heart health. They're just additive to the other things that we're seeing with semaglutide, tirzepatide.
Okay, so as a cardiologist, you're not taking your patients off statins anytime soon. Yeah.
I'm not taking them off anytime soon. I think that what we are learning is that there are statins that work better for some people than others. And if you're not tolerating your statin, which is a very real thing that can happen, you should definitely talk to your physician or provider about switching the type of medication that you're on. I like to say there's two big types of, this is a little outside, there's two big types of statins. One that dissolves more in water, one dissolves more in fats. If you don't tolerate one, usually people tolerate the other. So it's pretty easy to find one that can work with you.
Awesome. So on the topic of dementia, Alzheimer's, this is a field and area I'm extremely passionate about. Let's talk about brain health.
Yes.
Yeah, so let's talk about it. What are the benefits of this drug on dementia, Alzheimer's, brain health, neuroinflammation?
That's a great question that I wish we had this long answer of we figured out everything. That's a very active area of research right now. I mean, with how little we understand about the brain and neurobiology to begin with, we can only hypothesize of how these medications are contributing to it. But some of the things we do know are that GLP receptors are expressed in certain areas of the brain. And this is a lot of parts that are involved primarily with reward processing, things like the ventral tegmental area, the nucleus accumbens, basically the hypothalamus itself has a lot of GLP receptors that are really important in things like rewards, addiction. The inflammatory component that these medications have absolutely, I think, decreases risks of dementia, Alzheimer's, but whether it helps in things like apofolding or protein misfolding itself is a really interesting area that I think we should pursue more.
Yeah, that's definitely a topic of conversation. I go to the A4M conferences, and that's an area everyone's talking about. Now let's talk about some of the unusual side effects of these classes of drugs. I recently read one report of doctors prescribing this for addictions, specifically alcohol addiction, shopping addiction. Let's talk about why this even works in those pathways, right?
Yeah. So we alluded to that a little bit earlier, and that GLP is expressed in certain areas of the brain that are very critical components in the brain's reward system and addiction system itself. When the medication works and when it acts in the brain, it essentially reduces the brain's sensitivity for rewards. It modulates the reward and reinforcement mechanism so that when you have a substance that typically would give you that reward type feeling, you don't feel those kinds of cravings or that compulsion to engage in that type of behavior. This is especially true with things like appetite. When you feel full, you're not going to want to eat more. The other big one that is still, I think, being teased out a little bit is in how the medication works in reducing withdrawal symptoms. So after, for example, at any sort of alcohol treatment center or drug abuse treatment center, I think there's some really neat areas where giving patients these types of medications can help with those withdrawal type symptoms and alleviate some of the symptoms that typically are encountered during that withdrawal type process. So it's an exciting area, stuff that we still don't know everything about, but it's absolutely on the horizon.
Interesting. I get asked this question time to time, and it's, well, if it works in the reward pathways and I no longer feel the need to eat or shop, or how about other things like exercising or sex or whatever it may be that also works in the same pathways? How about that? Is there a reduction in other activities and reward pathways, I guess.
Yeah, that's a good question. I have not personally seen the decrease in other activities as much. It's primarily more food or substance related. The thing that you have to be careful of is that when you're starting this medication and you don't have those food cravings, your appetite naturally decreases. Sometimes we just feel too tired to exercise the way that we typically had before the medication. That's why it's, I think, really important to not totally, by any means, cut out all medication or all foods. You need to still make sure that you're eating proteins, balanced diet, carbohydrates, fats, that you are still having substance within your body. It's a very real possibility that you can develop sarcopenia and muscle wasting if you don't make sure that your body is well nourished with medications or with food.
That's why I have my protein shake next to my desk every day.
Perfect.
A couple tips. We had a question that came in. Can we touch back on how it helps kidney disease?
Yes, excellent question. So the big GLP kidney outcomes trial is actually expected later this year. But what we do know is that the surrogate markers, things like improvements in creatinine, improvements in your eGFR, your estimated glomerular filtration rate, have been seen in some of the clinical trials. The reason why this happens is hypothesized to be due to one, the improved vascular endothelium. In other words, more blood flow is getting to the kidney to be well perfused, allow those nephrons to effectively filter blood and urine to essentially work more effectively. The second is decreasing the pressure. If you have your vasculature that is not as stiff, more blood flow again can get to the kidney. And the second is the inflammatory, or the third is the inflammatory component. Some of the enzymes that are expressed in the endothelium of the blood vessels are also seen in the kidney around some of the tubules, especially the descending loop of Henle, if you want to go into your nephron biology, are expressed there so that you can have more favorable exchange of ions and proteins that reduce the pressure within the nephron itself.
Really interesting. Now, as we look into the future, do you think there are other areas of research or potential opportunities for GLP-1s?
We're only beginning to touch the surface. And my answer to this question actually changed this week. So the first part is that I alluded to earlier that retatrutide is the triple agonist medication that's expected to have results in the next year or two. The other really exciting thing is just this week, there was a phase 2 trial of a medication that's similar to the GLP. It's similar to tirzepatide, except the glucagon part works a little bit differently, but it's a once monthly injection, which is fascinating. Imagine not having to do injections every single week. You can do this once a month. And that's not even the best part of the medicine. The best part of the medicine was once you came off the medicine, people still had sustained weight loss or plateauing for weeks, if not months, after stopping the medication. It was absolutely groundbreaking. So that's a very exciting area as well.
Wow, what is this medication called?
The name escapes me. It's made by Amgen. It's one of those AMG number type medications. It doesn't even have a name yet, but it's absolutely fascinating.
So we're just scratching the surface with these sort of, wow, that's incredible. I hadn't heard of that. And what do you think that'll ultimately mean for our population as people? What would this mean?
Yeah, I think that the big thing that we're taking away from this is overweight, obesity is a chronic condition. Just like if you had high blood pressure, you would expect your doctor to prescribe a blood pressure medicine. There's no reason why we should think of weight and obesity as anything different. The stigma behind obesity of it's just the person's fault versus something that's biological, I think has real negative consequences. And I think we're seeing that because we now have medications that can control a chronic condition, I think that you're going to see a lot of really healthy benefits going forward. And just like you would high blood pressure, you take your high blood pressure medicine. For overweight or obesity, you take a medication and you help control it.
Now, would this be something that a patient could potentially be on for the rest of their life?
Well, as of last week, I probably would have said yes, but I think with some of the stuff that we're learning and that some of these enzymes that they're helping design stick around for a really long time. I think, the statin question of you take a pill daily, now we have twice yearly injections to help control cholesterol. I don't see why you can't do something similar with these types of medications. Imagine an injection once a year or twice a year that can last with you for the rest of the season is pretty incredible. And I think that we're absolutely heading in that direction.
Yeah, that's exciting. Wow.
Mhm.
I didn't even think about that. That is exciting. So a question came in. Can you talk about GLP-1 meds lowering autoimmune antibodies such as Hashimoto's antibodies, psoriasis, arthritis, etc.? Sorry.
That's a that's a great question, and it's not one we know right now. The data behind autoimmunity with these kinds of medications is really lacking. Um, I do not know of one off the top of my head regarding rheumatologic conditions, but it's a really good question. I don't see why it wouldn't. If it decreases things like TNF alpha, TGF beta, and IL-1, it's absolutely possible that it can improve other inflammatory conditions that are rheumatologic in nature.
That's amazing. Thank you. Thanks for touching on that as well. So, Dr. Sager, any last words for our community? Any last thoughts? Do you have any advice that you would like to give to everyone?
I think I absolutely love these types of medications. I think that they are the future of medicine in general. I think there's so many good benefits. I think you need to find a provider, a physician that you really trust that can talk through things, that knows you well. And if you want to start down this journey of being on these medications for any number of the reasons that we touched on during the session today, I think being very aware of the side effects, don't do anything rash, don't completely eliminate a specific food group, everything in moderation, stay hydrated, and then this will be a really easy endeavor for everyone in the future.
Wow. Well, thank you so much for your time and sharing your knowledge, your wisdom. I can't believe you were at the front lines of all the data and the research that was coming out and being developed. So thank you so much for everything that you do. And we would love to have you back with more questions to answer. Thank you so much.
Thank you. I'd be more than happy to.
Well, thank you all for joining us this evening. Tune in again next week as we discuss more topics and we spread the knowledge and joy throughout our community. Love you all. Have a good night.